Welcome to the University of Washington Tracheotomy Care Training video, module on Orientation to Tracheal Appliances. By the end of this video, we anticipate you will be able to describe the parts of a tracheotomy appliance using accurate terminology, discuss the types of tracheotomy appliances and their common indications, list the contraindications for various types of appliances. Standard tracheotomy appliances, or trach tubes, commonly have the following parts. The outer cannula describes the portion of the tube that is inserted through the patient's skin and tissue under the skin into the trachea or airway. The flange rests against the patient's neck skin and typically has slots for attaching tracheotomy tube ties that circle around a patient's neck. The connector is the portion of the tube that remains outside the patient's neck skin and to which a ventilator or ambu bag can be connected. The inflation line is used to introduce air into the cuff or balloon that may be present at the tip of the tracheotomy tube. Not every trach will have a cuff, but when a cuff is present, there will be an inflation line with a pilot cuff through which it can be inflated. An obturator is the device placed inside the tracheotomy cannula to create a blunt, tapered, and smooth tip to aid in tracheotomy tube insertion through a patient's skin and into their airway. It is used for initial trach tube placement as well as for reinsertion during most trach tube changes. The inner cannula is a tube that can be inserted through the tracheotomy tube outer cannula. It provides a lining for the tracheotomy tube that can be removed if the tube becomes fouled with mucus and debris. A variety of tracheotomy appliances are commercially available. Most tracheotomy tubes are made of plastic such as polyvinyl chloride, PVC, or silicone, but some can be made of metal. The commonest tracheotomy appliances placed immediately after tracheotomy surgery are cuff tracheotomy tubes. Inflation of the cuff prevents saliva and mucus from the upper airway as well as blood from the tracheotomy surgical site from passing below the tracheotomy tube and into the lungs. It also enables mechanical ventilation to be effective by blocking the trachea and preventing gases supplied through the tracheotomy tube from leaking out the upper airway around the tracheotomy tube. Almost all patients needing mechanical ventilation will need a cuffed trach appliance. Most cuffs protrude beyond the width of the outer cannula, but some have been designed to take up as little space as possible in the airway. This is called the TTS, or tight-to-shaft design. After the acute postoperative period, and if a patient no longer requires mechanical ventilation, their tracheotomy tube is commonly changed to an uncuffed tube. This tube enables passage of air around the trach tube, especially when patients are exhaling. In this situation, patients may be able to speak if they occlude the inner cannula while exhaling. This is described in greater detail in the module entitled Finger Capping. For patients with variations in their anatomy, special tracheotomy tubes are available. The Proximal XLT Shiley tracheotomy tube is frequently used for patients whose tracheas lie deeper in their neck or who have excess soft tissue between the skin and trachea. For situations where the area of obstruction is long and extends below the level of the tracheotomy, a Distal XLT tube can be used. For patients with irregularly shaped tracheotomy tracts, flexible tubes such as the Bavona tube can be used. These tubes can navigate tracts that curve or skew in different directions. This particular tube also has an adjustable flange so that the length of the tube can be adjusted. In this module, we provided an overview of the various parts of a tracheotomy appliance and reviewed some common types of tracheal appliances.